Dr. Alan Viglione is on the podcast today. I thought that was a great interview with him.
Yeah, he owns Montecito Concierge Medicine on Coast Village Road. He worked with us for a while in our office when he first got started. And he was telling us more today about how his practice runs and what his approach is, which is really a holistic, in-depth approach for patients looking for that type of medical care.
Yeah, he's very multifaceted, and he has a great new project coming up in early 2024 called Healthspan Montecito, where he's going to be doing a lot of great testing.
Yeah, cardiovascular health testing with the VO2 max and also a full body MRI. Yeah, we talked about a lot of the new age anti-aging procedures, and I think you'll find it very interesting. It's very informative. But what do I know? I'm just a vagina doctor. Alan, how are you?
I'm so good, my friend.
Great.
Yeah.
So, Alan Viglione, internal medicine specialist. Welcome to the Vagina Doctor podcast.
I never thought I'd be on a Vagina Doctor podcast, but very
come
happy to
on.
hear it. Very happy to be here.
So, your business is Montecito Concierge Medicine.
Correct.
And you've been in Santa Barbara for just a few years. And I think you're doing things in a really remarkable way. And, concierge practice is usually one that happens to older physicians in the last few years of their practice, when they've attracted patients for years and years, and they want to slow down a bit. They want to be able to give more time to patients, and they basically pick and choose their patients. So
That's right.
for somebody to do that who's not well established in town, it's pretty remarkable.
Thank you.
And you could either say, very brave or very stupid. But you're a year, you're 2 years into that, year and a half to 2 years into that, and you're very successful. So I think it's brilliant. And I'm just, it needs pointing out that this is a different way from doing it. But tell us about the practice. Tell us what you offer to patients and what your goals are with this plan.
Well, yeah, well said. I appreciate the intro. So just to piggyback off that real quick, there are two ways to enter concierge medicine. One is from the ground up, and one of them is from the top down. So to your point, most doctors go top down because it's safer. When we started our practice, we had nothing but 0 patients and a dream, a vision. And I think if you're going to go that route, you got to have a very clear vision about what you want. And we did. So, what we offer patients from day one to what we offer now, it's growing towards that vision. So I went into this because I thought there was a deficiency in internal medicine. I felt like it was becoming less relevant, not only to myself, but also to the patients. They wanted something more. So I sat down from the ground up and identified what I think internal medicine should include, and how do you get there, and what are the fundamental pillars of health and wellness. Do I want to take insurance or do I not? Like these fundamental questions. And we jumped into it. We just went off the launch pad. So to answer your question, what do we offer? So it's primarily concierge medicine, right? So it's 24/7. We do house calls. We do primary care, basic office procedures, suture, and all the sort of stuff that your primary care doctor generally does. But we also weave in what my vision of health and wellness is. And it's beautifully harmonious, focusing prioritizing sleep, diet, nutrition, exercise, mental health, which is a big ticket item in my world. Sometimes I feel like a therapist, but weaving it all in to a program rather than keeping them separate, disparate, distinct, and calling it internal medicine. So hopefully that answers your question, but really it's number one, identifying what you think wellness is. Number two, how do we get to that point? And then how do we build packages and grow as a practice when you start off with nothing? So how do you sell it to a patient? How do you tell a patient that this is important?
Yeah, because that's completely different than like what I have with my internal medicine doctor. No one's ever
Yeah.
explained it like that, or had a plan in place of what it looks like to have an internal medicine doctor.
Right.
So
I mean, to your point, Karen, I mean, not everybody thinks like that, but not everybody wants that. Some people want an internal medicine doctor that you see once a year.
mhm.
Not everybody wants a relationship with their physician, but what we're in the business of relationship building, and it makes it more powerful. And I think it makes it more, I think it's special, and it also affords a higher price point. So we have a very small, sort of like very unique, very concentrated practice.
But do you think that's because when you say some people don't want a relationship with their physician, do you think it's because they never thought they could have a relationship with
Yeah.
their physician? Because
Yeah.
I mean, that's what I'm seeing right now is that's changing a lot. Well, it's always been the case in our practice. I mean, it's
Mhm.
Duncan has a strong relationship with his patients. And right, I mean, that's what's unique about the office. But I think with internal medicine, it's a little different than GYN. And there has been sort of a barrier between the physician and the patient, which
Yeah.
you have taken away that.
Yeah.
And
Well, you're right. I think part of it is awareness. I think some patients aren't aware that they can have a relationship with their physician.
mhm.
But I think another element of it is, what we kind of loosely call medicine 3.0 or participatory medicine. Not everybody wants to be an active participant in their health. Everybody in this table is just sort of obvious, right? And all
Mhm.
your patients too, or most of your patients too, they're active.
Right.
They reach out to you. And the patients in our practice, we're involved in all elements of their care. Not everybody wants that. And you might find
Mhm.
that interesting too, but I have many patients who join our practice and they just want the once a year physical.
Mhm.
And I have other patients who ask me, sometimes I feel like the bartender in Cheers. Like they'll come to me for every little thing. Who's a dentist that you recommend? You have a dog sitter you recommend? And
Oh yeah,
there's
we
an
get
element
that
of
too.
trust.
Yeah.
Yeah, right. You're in the game of trust building.
Mhm.
And it's a really cool thing. But to your point, I think it actually is becoming more and more common. And I think the reason why is because of discussions like this. You
Mhm.
raise awareness, and then someone listening might say, "Hey, I want that relationship."
Yeah. When you say 3.0, is that your terminology?
No.
Okay, or does that mean something
Yeah,
that
it
am I
means.
supposed to know what that means?
Well, here's the concept though. Medicine 1.0 is like rubbing sticks together. This is like
Okay.
Hippocrates. Medicine 2.0 is like the generation of penicillin. And that's medicine 2.0 really sort of thrived in the acute emergency game. How do you fix somebody? How to cure somebody? How to keep them alive? Medicine 3.0, it's a term that was in Peter Tia's Outlive book.
Okay, yeah. I
Yeah,
have that book.
he's a
Yeah.
great
Yeah.
writer. Great. I mean, he's got a great podcast too.
Mhm.
But medicine 3.0 is defined by the age of proactive medicine. So now, how do we kind of take a step back in the world of preventative medicine, and how do you prevent the problems that are sort of inherent in medicine 2.0? It's a whole new paradigm shift.
So when a patient first comes to see you, you essentially explain this whole circumstance to them, and then they have the ability to choose what level of care they get from you, and what's
Correct.
included in a certain period of time.
Correct.
A dollar amount.
Correct. So part of it, it's like a game of poker in a sense. You really need to get to the core of what they're looking for.
Right.
And I'll have a husband and wife sort of in the same room. One of them wants the higher level care. Another one says, I don't really want to engage upon that, at least yet. And you have to build trust. You have to break down barriers, but you really have to. I mean, I consider myself a consultant in many ways, right? So think about this. We have our concierge medicine world, which is 2:00 in the morning, you get woken up for, earache or whatever. And then there's the whole world of the preventative proactive medicine. And we're dabbling in this world of longevity, anti-aging medicine. But not everybody wants that. Some patients that come into our practice only want that. So you're right. So phase 1, when we have our initial intake, we review their whole health history. I spend a lot of time talking about their family history because it helps me think about what I need to zoom in on.
Mhm.
Their cardiac history,
Yeah.
cancers in the family. Sometimes we'll weave in genomics testing, but then really come up with a game plan concordant with what they want.
Yeah, longevity is huge right now. So we talked the other day a little bit about this and your thoughts on it. And I've been thinking about that since. So I'd like to kind of revisit that a little bit with you. And I know, Duncan, you do as well.
Yeah, absolutely. And I think when, we chatted last week and we talked about the levels of care and you made the reference to the low-hanging fruit, the things that the patient needs to address right away. And the other end of the spectrum is the magic pill that's I'm going to take this and I'm going to be well forever. And I think that needs to be explained to patients sometimes because they're often wanting the other. And relative to that, and I think it's an appropriate time to just bring this up, the North American Association of Anti-Aging Medicine sort of set itself up as a standard of what people should need in terms of qualifications. But as you and I agree, that's not pertinent most of the time. It's not necessary to do that, or in fact, it's too wide, it's too broad to be of great help. But what you're doing, as well as giving this care, you're giving you have a diagnostic ability, either from just doing a physical exam, but you also are developing methods of evaluating patients through your the accessory functions that you have. Yeah. Can you go into that a little more? The VO2 max, the MRI, and that type of thing.
Yeah. So I really do think the future of medicine is diagnostic, and kind of going to that 2.0 versus 3.0 transition, we have an extraordinary wealth of diagnostics to our disposal, and the internal medicine community is, I would say, cautious with regards to the transition. So we're not talking about standards of care at this point, but when you're trying to personalize a wellness approach for a patient, defining what might actually help facilitate that really helps us springboard into what additional testing that we do. And the way I structure my practice is we sit for our initial intake, and I get to know who they are. I get to know what their goals are. And then we go down these really fun rabbit holes to achieve it. And higher level diagnostic testing is a big part of that. So I'll give you a few examples. Right now, I'm in the process of creating another company. It's called Healthspan Montecito with a business partner of mine, Wally Arnold. And we're looking to bring MRI, so full body MR screening, no radiation, full body diagnostics to Montecito. And then within that, bring on a CT angiogram. So this CCTA, it's called. There's this Clearly study. It's post-processing software that weaves in artificial intelligence to identify the cardiac vessels with extraordinary detail. Hard plaque, soft plaque, higher level cardiac screening is now possible, and something that's trendable. Never was it trendable. We're talking stress tests or Lexia scans, nuclear medicine scans, stress echoes, continuous glucose monitoring. So if someone has metabolic dysfunction, right, we do our baseline lab work and we define, okay, you have some elements of metabolic dysfunction. Your insulin level, your fats and insulin level is a little higher than I like. Your blood sugars are a little bit higher than we like. Let's dive deeper into this and let's get you a Dexcom or a Libre Free, a continuous glucose monitor, and see just phase one. Just see how your body reacts to your usual lifestyle. You can identify high spikes after certain meals, right? So then this kind of gets into how do we personalize your nutritional regimen.
Yeah.
But I mean, there are so many fun little tools. I can tell you the ones that I'm really passionate about. So full body MR, CT angiogram, specifically a Clearly study.
Wait, what's the difference between that and like the calcium score, right?
So good question.
Okay.
A coronary calcium scan has wider slices and it's looking for calcific deposits in the coronary vessels. Calcific deposits.
Okay.
So if you're going to look at the plumbing in your house and you see calcific deposits, you're talking about stuff that has grown over 10, 20 plus years. This is end stage stuff. And heavily irreversible, that defeats the purpose of our whole mantra. The beautiful thing about this Clearly study, CT angiogram with IV contrast, is that it looks at and identifies soft plaques, so gummy plaques, before they become calcified, i.e. reversible. So if I have a patient, this is what the sequence that I'll generally do. I have a patient that's say 45 years old, and they have some risk factors, coronary artery disease. They have high blood pressure. They might have a family history. And I want to dive deeper into their coronary status beyond risk. Then I'll order a coronary calcium CT scan. If that coronary calcium CT scan shows an unusual high level of plaque for their age, then I'll institute an aggressive reversal protocol. We'll dive into all these little tenets of health and wellness, from sleep to nutrition. Then I'll chase it and see exactly how much gummy plaque we're dealing with. And then I'll order a CT angiogram. CT angiograms are thinner slices, higher sensitivity, but they also give that additional detail with AI about this gummy plaque stuff. So it's a deeper nosedive into cardiac risk.
Does the calcium score test, they don't give you any information on that test. It just says, what does it say again? I had one done. It says positive or negative or something like that, or zero? Or...
Yeah, it gives you a score,
okay,
as the name implies, and the score can be 0 to 400 plus.
Okay, so if you get a 0, let's just say.
That's great.
Okay, I got a 0. But I still am questioning whether they saw what they were supposed to see in it. So is this other test more conclusive for you say, the soft?
Yeah. Yeah, the game, you're bringing up some really great points, Karen. The game that we play right now is pre-test probability and post-test. This game is statistics. And if someone's entire risk score is optimized, they're 25 years old, they have no family history of coronary artery disease, blood pressure is perfect, they exercise 5-7 days a week, right? Perfect. And I do a CT calcium score on them or a scan, and I see a score of 0, the negative predictive value is extraordinary. It just supports what I think. Mm-hmm. Now, imagine the opposite. You're 300-pound obese smoker, horrible lifestyle, never exercise, and you get a score of 0. Would I believe it? They have all the risk factors. Now, maybe they do have some sort of genetic anomaly, and I can nosedive into that too and look at some genetic markers for calcium deposition.
Yeah.
But in a patient like that, if I won't believe the scan, if it's a low score, we usually kind of age match it to see where you sit based on your age met population. I probably wouldn't order it. I'd probably jump right into the better one. Mm-hmm. So that's how I think about it. But as an initial screening tool for this low-hanging fruit that you mentioned, Duncan, I mean, it's a beautiful tool.
That's great.
There's some other tests that we've talked about before, and we've been implementing in our office, such as the gallery test.
Yeah.
Incredible breakthrough.
Love it.
I think blood tests that can tell you whether you got cancer or not, basically. I mean, it's as simple as that. Not cheap, but it's certainly it's worth it to most of the patients that we see.
I think so.
To do those things. With a very high confidence level in the results. Another test that we've been doing as well, as you know, is the bone score.
Oh yeah.
Developed here at UCSB, available I think in Santa Barbara and almost nowhere else in the rest of the world.
Yeah, correct.
I mean, they're doing studies at Mayo Clinic and another big teaching institution, but it's not available to anybody else. Correct. I mean, they're you and me and Alta Orthopedics.
Correct.
They're the only places that people can get it. And I think one client came from New York to see you and have the bone score done. Mm-hmm. Accurate, reproducible, safe, really phenomenal test. And that's just generated by this little town. I mean, there are things like that are just the beginning of the wave of higher resolution of medical issues. And I mean, what you're talking about, the CT is obviously part of that, and it's really phenomenal. It's just, I mean, people are just wanting that sort of information, have confidence. I mean, it's really, for want a better word, it's almost family planning. Okay, it just happens to be a figure of speech that we used in my specialty. What about peptides, metformin, low-dose naltrexone, glutathione, NAD.
Yeah, we get so many questions about these longevity peptides, and so much controversy right now about all of them. So yeah, we'd love to hear what you have to say. We're kind of gathering information right now about a lot of this, and we call it deconstructing anti-aging, because it's
yeah. Well, this gets into the conversation that we had just loosely the other day about higher level anti-aging. You know, phase one, start with the low hanging fruit, personalize a wellness plan, right? And then I get a lot of patients that ask me, what are the optimized supplements for me? And I don't think there's a one size fits all package. So I don't just say, here's your longevity packet. And some doctors actually do that. And some of them profit from it too.
Oh yeah.
Right.
The whole supplement thing. Yeah.
Yeah. And I think there's an easy way to take advantage of that. The thing that bothers me inherently about that is I like to have testable data. So what I generally do when patients want that higher level longevity optimization, I'll do another test called the Genova NutriVal. You guys familiar with that?
Yeah.
Yeah, it gives me these major categories. Antioxidant health is one, B vitamin health, omegas, right? And then toxins, including mercury. So sometimes you can optimize your like oxidative stress on the body, not by adding another pill, but just doing something different in your life. And if it's a lifestyle measure, you could decrease your large fish, right? If, in the example of mercury. But it also goes through the antioxidants that are high value for you. ALA, alpha lipoic acid, glutathione are a couple popular ones. You know, you can see if you're deficient in antioxidants, and generally those are patients that have very high oxidative lifestyles, whether they're on the move or even stress begets oxidation. Certain food groups can promote oxidation, and glucose and carbohydrates tend to be high inflammatory food groups. That's why we generally advocate like low glycemic or low carbohydrate food items. But before I get into a deeper conversation about the supplements and the medications that might be personalized for someone, I do this test so I can test it, like get a baseline and then implement something and then retest. But what we're kind of getting at right now is what are the medications that can slow down cellular aging? And there are a lot of clinics and there are a lot of patients that will do anything to slow down that process, and they'll throw experimental medications at you. And I'm not opposed to that by any means. I think life is a risk-benefit analysis. And so there are a few enzymatic pathways which they're ubiquitously targeting: AMPK pathway, sirtuins. There's rapamycin, which hits mTOR, which is literally a target of rapamycin receptor. There are a whole bunch of transcription factors called...
You're speaking another language right now.
Yeah, so slow me down at any point, but I'll summarize it in one sentence.
Okay.
Supplements target very specific enzymes which slow down or modulate the aging process. And you can pop one of these enzymes, you can pop all these enzymes. Some of them are better studied than others. Some of them are more experimental. Some of them have never been studied in humans, like rapamycin, but have extraordinary promise. And we do have patients that engage in these, and I do have patients that are on these. I think metformin is a great one. I'm on metformin. It modulates my blood sugar. I can see it in several different testing platforms I do. And there is good data, although it seems to be somewhat mixed, about its influence on longevity. There are other ones. There are autophagy supplements, which are thought to clear old debris in the human body, and in laboratory mice, Drosophila, and certain model organisms show benefit. We haven't seen that in humans as of yet. But think about this. If you're coming up with a personalized regimen for a patient, and a patient doesn't want to take that small risk in something that hasn't been studied in humans, I would say don't take that risk. If you're sitting with a patient and everything else is optimized and they really want to take that next level and the risk benefit is in their favor, then we do play these games with patients. And so what I try to do to make it as analytical as possible is I say, okay, if we're going to start this medication on you, whether it be rapamycin, you have to do it in a very safe manner, at least by the best data that I can find. But let's start tracking markers. So we're using this to lower inflammation. We're using this to optimize oxidation. Let's repeat a Genova NutriVal 3 months in.
Oh, yeah, that's good.
Right.
Yeah.
Or I'll check a few stress markers through our local Pacific Diagnostics, interleukin 6, TNF alpha. These are tests that are available through local laboratories. And if it's doing what we want it to do, you should see numbers come down. Right.
Yeah.
But my inherent problem with just using medications for the sake of medications is, what's the end point? You're going to have somebody on a medication for 30 years, or a lot of our guys or women, they start off in their 30s, 40s, 50s. They want to get ahead of it, and I don't blame them, right? You can feel the aging process happen as early as 40. At least that's what I feel. You got to have a lot of motivation to put somebody on a medication potentially for that many years.
So for both of you, I have a question. Do you think Dr. Google has made your job as a physician harder or easier?
I'll let you answer that, Duncan.
Wow. Well, I think it's I don't have a solid answer for it, because there's certainly good and bad. It's good for patients to be informed. We want them to be involved, and we're doing this the same in our practice as you are. We're involving the patients in the decisions that are made. We're not just telling them what they need to do. We're making suggestions and discussing it with them. So for them to have more knowledge, more education about it, it's great. On the downside is if you get into Google, and particularly if you go down the rabbit holes a little bit, you get into really bizarre treatments that this didn't even deserve a phone call. It just wasn't worth it. It's silly. But I think overall, having the patient well informed is beneficial. So I'd have to be sort of 60-40 on that.
I like that ratio. I think it's the future. It's not going anywhere.
Oh.
Patients have access to information, right?
Going to that, something measurable.
Wait, I want him to answer the question.
Sorry. Go ahead.
Well, I feel the same way. The problem with Google is that you start Googling things and you're going to get fed down a rabbit hole, right?
Mm-hmm.
You're not going to get both sides of a story. And then the information that you search is going to feed another algorithm, which kind of gives you more information about what you're looking for. So patients tend to come in with an extremely biased opinion about something.
Right.
I think it is what it is. I have a love-hate relationship as well. I use Google. Sometimes if I have to recall a certain rare diagnosis, you put in something, you'll get it out. I think that as we start getting more to AI algorithms, it'll be a little bit more conscious and probabilistic. What I mean by that is, Google doesn't rank based on probability of an outcome. They rank it based on number of hits.
Mm-hmm.
So you type in the most generic sentence, fever, itching, whatever, and what are you going to get? You're going to get cancer, and you're going to get lymphoma and other things, because, whoa, I see that. I'm going to click that. I'm going to click that. I'm going to click that. When you start getting into more AI-directed algorithms and ChatGPT and whatnot, you could actually weigh that a little bit more from a physician's mindset. But I see it as a tool to supplement what we do. That's where I see the value of it. And we're all for patients being informed. I think we want patients to be informed. It's all part of the discussion.
But I could see how it would be, especially for you, Dr. Viglione. Well, and for you, Duncan, too, because I take the calls where people have already diagnosed themselves with whatever it is, and they already know the treatment. So then they come in and they're sometimes arguing about, no, I need to do this. So they already have it figured out. So,
it's challenging.
Yeah, the patients that don't have an open mind any longer, they think they've made the diagnosis themselves, and they just want me to do it, to fix it.
Yeah.
That's frustrating.
Yeah.
For sure. Has he answered that question well enough that I can ask a question
you
now?
may.
Okay, all right.
Do you remember your question?
Yes.
Medium mental
Strangely,
status.
yeah, really. It's a good test of that. Telomeres and NAD.
Yeah.
So telomeres are something we can measure. And it seems to me that it's the only direct evaluation of longevity that has been shown to be reliable. Not looking specifically at inflammation and so on and trends, but just here's something that we're measuring now, and a positive effect on it by NAD.
Yeah, there is data there. And so to expand upon that, Duncan, so telomeres are the little stretches on the ends of chromosomes which stabilize them. And there's an enzyme called telomerase which does that. And we've known this since I was in, this is one of the first things we learned in like 7th grade biology class, telomerase. And
not when I was in 7th grade. Or if I did, I don't remember.
I'm not even going to throw around dates here, but but telomeres are something that's trendable. The laboratory that you use matters. So there are different testable sites and locations that can measure telomere length. So you have to be a little bit careful about that and go with a laboratory that has this as much validation as possible. But yes, there are correlations between NAD and telomere length. And it's one of the things that a lot of the longevity centers actually have picked up on.
Yeah.
So NAD, so NAD, do you want to dive into that, or is it irrelevant?
No, not really. It was something that can be done that I think
Testable.
you've been providing in the
and
office.
It was like,
Correct.
it started with these very long drips, and now you're hearing about people just getting a intramuscular injection or taking a pill. So now it's kind of in a different place. So let's kind of go through that, I think.
So NAD drips are what you're referencing. They're generally very long drips, very expensive drips too.
And people feel funky during them.
Yeah, I've done them. Sometimes we have to slow down the drip rate because it can cause palpitations and funky feelings. We've had to slap an EKG on patients mid-drip. It kind of, this is the classical symptom. It's like this internal itch inside your chest. NAD injections, intramuscular injections are a thing. You can't use as high dose, but you can do them with high frequency. There are NAD patches that get the NAD in. So the logic is that you're going to ingest a NAD pill, it's not going to get absorbed properly. But some researchers have circumvented that by formulating it with a liposomal formulation, so liposomal NAD. But to the deeper question here, how do we test this? And you mentioned telomeres that can show an outcome from NAD therapy. It actually came to my attention recently that there are some laboratories that can evaluate intracellular NAD, and you can do this with glutathione as well. Actually, just like demonstrate that your levels are going up. PDL, Pacific Diagnostics, again has a glutathione test, and there's some specialty tests where you can actually look at intracellular NAD levels.
Oh wow!
Yeah, so these things actually, I think
it's a blood draw.
Yeah,
and
it's a blood draw.
They look at those specific.
Yeah. So exactly. So you can trend these things with higher detail than once thought.
So if somebody says, "Oh, I want NAD," do you do a blood draw first?
No, we don't. And there are a lot of reasons for that. I think everybody can benefit from NAD. For our patients that are on NAD packages that want to come in with high frequency, it's like vitamin C as well. If someone comes in for a high dose vitamin C drip, I don't go into too much detail because in our toxic universe, I think everybody would benefit from it. But if someone is coming in frequently for high dose vitamin C drips, then I start zooming in a little bit more. And I start looking at G6PD and certain enzymes to look for potential complications of that intervention. Now, NAD, there are no known complications, right? But I try to give them as much bang for the buck. So the whole point of at least what we do and what you guys too is to optimize health. It's not to create a longevity clinic to just have a puppy mill practice.
Right.
So that would be the patient, the client that I would bring this up.
Right.
Along those lines of what patients want to do, the subject of physician abuse has come up. I think a concierge physician is ripe for that. Actually, a concierge physician in this case is the low-hanging fruit that we were doing.
Do you have coverage yet?
Yeah.
Okay,
so
good.
you have to cover your tail end, right? So we're talking about malpractice coverage here. When you're doing experimental stuff, you have to have coverage on top of coverage on top of coverage. And you have to do it in a safe environment. So, and with that comes consent forms, and you have to be extremely transparent with what you're doing and what the risks and what the benefits might be. Now, mind you, our patient population, extremely loyal. Like they're part of a concierge practice. If we were strict longevity, then I wouldn't know much about these patients. And because we're not, because we're just a very boutique concierge practice, I have a very strong relationship with every patient. And in as much, we really kind of understand their goals and their worries, and we address each of them. I mean, really, when you get into physician litigation and liability, I don't know a percentage off the top of my head, but I would say a high percentage is miscommunication.
Oh, absolutely. Yeah. Good. I have two questions, maybe final questions, but whatever happened on Coast Village Road? I mean, since you and I have known each other, which is just 2 years.
Yeah.
There's this collection of passionate, forward-thinking, high quality of care facilities that there was nothing there when we moved there.
Right.
I'm proud to say we were the first ones there. Okay. But you came in, UCLA have come in, Cottage Hospital have urgent care. We've got these very high level of plastic surgeons, cosmetic surgeons available in our practice as well. And I mean, it's just really bizarre. There's this little, we want to call it the Harley Street of Santa Barbara, but it's just I don't know that there's a reason for this other than the fact that it's happened, and passionate work evolves other passionate work. Just wondered if you had a comment or if Karen had a comment on it also.
Yeah, I'll jump in first, Karen, and then I'll hear your take. I think your last sentence resonates. Passionate work begets passionate work. You were the OG, Duncan. You were the first one over here, 1250 Coast Village Road. And, from there begets awareness in Montecito Journal and whatnot. And so the name gets out there. You guys provide quality, great work. And then it spreads like wildfire. Before we came, believe it or not, I had this conversation with the prior physician I worked with down by Cottage Hospital. And there's strength in the herd. And when I said I wanted to go to Montecito and there was a tremendous need in that community, I was almost balked at. I don't know your experiences, but, it's out there in left field. You can't round on them readily. If you're not by Cottage Hospital, you have to stay by Cottage Hospital. But I think what we're finding is that, first of all, Montecito residents, your patients, my patients, love having local access.
Yeah, absolutely.
So the word of mouth goes crazy. Great care. And we're at the point right now where I have specialists, subspecialists, whatnot, reach out to me regularly. I go to lunch meetings all the time about people asking about Montecito and trying to forge partnerships and relationships. And I think part of that is simply the extraordinary success and how it's percolating through that community.
Yeah.
I mean, it's astounding.
Yeah, it really is. The second fun fact
Wait,
about
I want
you.
to comment.
Oh, okay, sorry.
So now you have to remember your fun fact again.
All right. So one thing when we first moved to Montecito, it was we had a lot of our patients that were so excited because they live in Montecito. Then we had our patients like, oh, you're going to raise your prices. It's like, no, we're not. It's actually less expensive at this moment to be in Montecito than where we were downtown. Now that we're in the community and see that it is a community, much more so than when we were in Santa Barbara, it feels more like a community of people. The street feels more like a community. Having you there is amazing because, just a few weeks ago, I called you about a patient that really needed to be seen right away. And you answered the phone. Things like
sounds
this,
weird. We
right?
answer the phone.
It doesn't happen.
Yeah.
It doesn't happen. Can you see this patient? Yes, I can see them today. That doesn't happen. That's not real life. Okay. Talk to anybody. But that's how it is. And when our phone rings and there's someone, that needs to be seen. Yes. Sometimes it's something that we're not even doing. He's not delivering babies anymore, but it's a pregnant person. Yes, come in. They're visiting from the UK. come in, we'll see you. And just that people are just so grateful for that.
It's a question. The immediate answer is yes. We can handle that.
Yeah.
We can help you.
Yeah.
Okay. Even if we don't do that ourselves, we know where to send this patient. Either they call a multi-specialty practice in Santa Barbara and they're given an appointment for 3 months away.
Yeah.
And that's no exaggeration. That's the way it happens. Or they go to urgent care or the emergency room.
Yeah.
Yeah. It's changing. It's changing. And I think it's great. And Sutter Health is coming in, right? And UCLA, whatnot. I love it. I'm not scared by medical practices coming to the community. I think raising the bar for the entire community is a great thing.
Absolutely.
I do too. And I think the more quality, people there doing really great patient care is just going to benefit everybody. And again, I loved being able to call you that day and that you answered the phone. I felt like God.
Anytime,
I was like,
Karen. I was sitting there with my feet up, reading the New England Journal of Medicine.
So thank you for that.
Sure.
Anyway, we can go on to his amazing fun fact.
You do it. Go ahead.
Well, I want you to say it, Dr. Viglione. What is your fun fact? What is your fun fact?
Well, you guys asked me, what's fun about you? What's unique? And, this is how the doctor's brain works. Well, I trained here. I did this, blah, 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 right?
Mm-hmm.
There's nothing fun about that. But I thought it was interesting to mention my adoration for Seinfeld.
Yeah.
But I wrote on that little fun fact was that, every episode, every little line, I'm just cataloged in the back of my head. And so, you come across another Seinfeld fanatic and they'll mention something, master of my domain, just like a snippet or something.
Yeah.
And you can just recreate the whole episode in your head. And I think that's fun too, because man, I have a hard time with names. I mean, I have a hard time with a lot of little minutia and small details of our day to day. But in the back of the brain, this stuff is so consolidated and it's just fun. I think it's entertaining.
I think it's amazing. And so did you have to see the episodes more than once to get that?
Yeah, Seinfeld was, I grew up with Seinfeld in high school and whatnot. And all my friends used to joke and we'd use these lines and whatnot. But it was always and it probably still is, like that background TV, when you've got your laptop open and you just have something in the background and you look up and you smile and it's, pure and it takes you back. But yeah, I've probably seen every episode, I don't know, 50 times indirectly. Yeah. It's a different type of humor. But I think it's also cool from a scientific perspective, right? Like how the human brain works. But you hear one word and whatnot, and to recreate a broader context around that word.
Yeah.
And that's kind of what I thought was entertaining.
Well, Seinfeld is really trending right now too, because it's on, it was just released on, was it Netflix or now all the younger generation is watching it. So it's like, they're just discovering it for the first time. So when you say Seinfeld, people used to not know what you were talking about. Like my daughter. So, and another question we asked you was about pushing boundaries. And if that's always been the way you are, and you said it hasn't been. So
yeah, no, it hasn't. I think it would be easy to say, oh yeah, right. I'm always just like, when I was six years old, I was, like leading the charge for X, Y, and Z. And the truth of the matter is, the one thing that I did have was a clear vision of what I wanted. And you kind of go through your physician career and you learn, you check things off and you learn that this isn't right for me. My journey was, I loved internal medicine. I loved putting things together. I mean, there really wasn't a question about it. But do I love seeing 30 patients a day? No. Okay, go down this route. So now I want to spend more time with patients. Oh, good. I'm in a concierge practice. Now I'm seeing 15 patients a day. Okay, that's not it. I want to take that down even more, right? But it's about knowing your end game. And I think I have had a good idea of my end game, and I'm close to it. Yeah. I think the only thing I would do differently in the future, we have a beautiful concierge practice. We've got great relationships with patients. I have 200 patients compared to 2,000 patients when I worked in Newport Beach. But I want to get heavily in the consultation game for medicine. Honestly, this is another end game too. Bring the executive wellness exam to Montecito and Santa Barbara at large, and have patients fly over from all over the world, come for a full day of data analytics and consultation, and give them a full report and help guide them into a wellness plan.
Yeah.
I think big picture, I don't need to be the guy looking in the throat and saying your tonsils have some exudate or whatnot. But I think I can provide bigger value to health guidance. And I think that's a beautiful thing. And I think we're right on point to get there.
I do too.
Yeah. Help more people, right? So concierge medicine is great. I can provide extraordinary care to 200 patients, right? But there's a limit because I take that to 300 and it waters it down, and 400 and I'm working the way I used to.
Right.
So that's not the answer. So how do you affect and how do you make it a broader impact?
Right.
Yeah, and the place you're opening right up the street from where you are now.
Yeah.
What's the name of it?
Oh, it's Healthspan Montecito.
Healthspan.
Yeah.
And when is that going to be ready?
So phase 1 launch will be the end of this year. So that's where we're getting the VO2 maxer and the DEXA body composition analytics. So I really do value the movement aspect of wellness. And, what better way than to internalize it and say, hey, listen, I'm a little worried about your cardiovascular fitness. Let's get a data point. Walk 2 doors down.
Mm-hmm.
So that'll be up and coming soon. And then the next phase will be to get the MRI and the CT scan and maybe some other imaging equipment. And that's a few doors on the other direction or any other direction. So
for us, if we're sending people your way and they're not in your concierge practice, how does that work?
Yeah. So this Healthspan Montecito, by the way, that's to serve the community.
Okay.
That has no relevance whatsoever. And we do very limited fee for service. For the most part, I want to keep our practice, I want to keep my attention on the patients, not kind of, buzz all around and treat non-patients. But, and I say this sincerely, whenever a doctor calls me up, I'm willing to help.
Yeah.
And for the people that are near and dear, or specifically other physicians that haven't had their own health diagnostics dived into, I say, come on in, let's draw your blood and have some fun with it. But of course, for you guys, I mean, if you need anything, but we do a very limited percentage of that.
One of the things that we mentioned briefly earlier on was the North American Academy of Anti-Aging Medicine, and them setting themselves up as the credentialing body for specialty training in anti-aging medicine. And so I looked into that and got their textbooks with a plan to study and move in this direction, because I was wanting to find out more. I was wanting to know more about the peptides and anti-aging medications, the things we've already mentioned. When I got the books and I was looking at them as a research basis, I couldn't find what I was looking for. It was too esoteric, too broad, not practical for me at all. What's your experience?
Well, I had actually an identical experience to you, Duncan. So I got the books and enrolled in the fellowship program for American Academy of Anti-Aging Medicine, and started reading the books. And admittedly, I was somewhat disappointed.
Yeah,
I think what I wanted was more of a deeper understanding and a very practical approach to how do you implement this into a practice. And what I didn't find was cutting edge stuff. So I transitioned from the textbook learning to essentially learning from colleagues. I think the best way to understand anti-aging medicine is to engage in dialogue with those other leaders of the field. And the concept of the longevity fellowship was essentially that. It's you get speakers from the thought leaders in the field and you kind of put it into an educational platform. And, I found when I started that fellowship that I was just being directed towards the podcast that I can listen to anyway. And it's such a new field. I mean, you got to be able to weed through the challenges and weed through kind of like the noise. And I think that's why the fellowship came about. But I feel like it's simpler and probably more linear to engage in these podcasts and dialogue and conferences independently. And
I agree. Yes.
Yeah. And the books, by the way, I mean, the books weren't even complete sentences. I mean, like, it's hard to get a broad context understanding if you're just like reading, bullet points. Literally, it was bullet points. It wasn't even in paragraph format.
Yeah. Thanks.
Yeah, you bet.
Well, I have just you hear all these names and people throwing around, like David Sinclair, and who's the other person?
Well, Peter Attia, I mentioned before.
Peter Attia.
Yeah.
That this type of medicine is what people are doing right now. And we both have patients that use these clinics in LA. So what is your comeback for that? Or what do you?
Yeah. Well, I support those clinics. I think there's a role, and I think the idea is they're bringing some of these higher level diagnostics to those that don't have a boutique concierge doctor, right? So remember, I mean, concierge medicine and longevity are quite independent, but I think what it lacks is you have a day where you get all this diagnostic tested, and you have somebody throw the results at you and saying X, Y, and Z. Go back to your own primary care physician. What I'm looking to build is to weave that into primary care. And think about it. If you're Fountain Life and you're going to do a day of diagnostics, and we're going to check NAD levels, we're going to check TNF alpha, and we're going to show that some of these little antioxidant discrepancies or abnormalities are fixed. What they lack is that continuity aspect. It's designed for the person that doesn't have a concierge doctor, that wants to go once a year, kind of for that executive physical, but taken to another level. And I think that's a great role. I mean, it brings awareness to it.
Yeah, which is good.
Yeah, Fountain Life is, one of the owners is Tony Robbins, and he has a great book where he introduces this, and I found it inspiring.
Yeah.
So I think there's a role for it, but there's a limited role because and it has to be a limited role. It's defined by a one and done. It's a one and done consultation. And, I know that they can try to weave in the concierge aspect to that, but you're never going to achieve it. I mean, you're never going to have a high-end concierge practice if your physician is in a different state, who can't prescribe you certain medications and, can't look in your throat when you need to. So you basically have to choose what your battle is. And I think that they're choosing the longevity angle of it, which is perfectly fine.
Right. It's one-dimensional.
Yeah, I think so.
Yeah.
Alan Viglione, thanks for being
Thanks, Duncan.
with us today
Always
on the
a pleasure.
Vagina Doctor podcast.
I love it. I love it. Thanks, guys.
Thank you.
Anytime.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.